Hi, this is a pause for reflection, characterizing the baseline of reflection and metacognition among surgical residents. My name is Christian Morrill, and this project was done in conjunction with Dr. Jennifer Steinman of the Department of Surgery at the University of Pittsburgh School of Medicine. Surgical educators and residency programs are continually challenged to find the most efficient methods of maximizing clinical competency and technical skill amidst an ever-evolving landscape of surgical practice. Historically, a trainee's cumulative operative experience has served as the keystone surrogate measure of surgical expertise. In recent decades, however, advancements in the areas of cognitive psychology, productivity, and surgical education have garnered greater understanding and definition of surgical expertise. A multidimensional concept, surgical expertise can be broken into general and adaptive components that are both domain and context specific. Many curricular advancements have been implemented to target various components of surgical expertise. Curricular advancements include prioritization of competency-based evaluation of ACGME core competencies, individual coaching, mentorship, case-based learning, flipped classroom, and high-impact simulations. Inherent to these curricular adjustments is a subliminal role of directed reflection and metacognition. Directed reflection is a recognized principle of learning theory in general education literature and is increasingly implemented into undergraduate, postgraduate, and continuing medical education across a variety of health professions. Although several definitions of reflection exist, a unifying definition would be a descriptive, analytical, and critical reasoning process to make meaning of experience. Perhaps the earliest definition in 1930s, John Dewey's reflective criteria included linkage of experience, sharing experience with others, awareness of attitudes and emotions, and deliberate practice. Across these definitions, reflection has been shaped as an iterative process of varying levels of attention and effort. The iterative domain of reflection recognizes triggering effects of experience, while the vertical dimension regards the different levels of reflection from descriptive to deeper levels of analysis and critical synthesis. In the realm of surgical education, implemented reflective activities include journal writing, self-evaluation assignments, and protected reflective time. Despite early integration of reflective practices, there is little evidence to support and inform such interventions, and innovations remain largely theoretical. Empirical studies on the nature of reflective practice are insufficient. In medicine, as far as we know, they are virtually absent. The literature to date is confined to attempts to implement reflective practices or proposals of educational approaches for its development, with few exceptions in nursing literature and education, in which the theme of reflection has been further explored. Precious few studies have sought to define which behaviors constitute reflective practice in the health professions. To our knowledge, no studies have formally reported pre-intervention reflective practices among surgical trainees, let alone how these baseline reflective habits change through time and training. As a result, this study aims to characterize the prevalence and types of operative reflection practices among surgical residents at a U.S. hospital, and to explore whether the practice of reflection differs by PGY or postgraduate year level. Our methods consisted of a 1-hour focus group consisting of 3 residents, as well as a total of 5 additional individual interviews were conducted within general surgery residency programs at the University of Pittsburgh School of Medicine and Mercy Hospital. Identification of reflective practices and activities among surgical residents were identified using a semi-structured interview with 5 open-ended questions on the goals, topic, method, frequency, and use of operative reflection. Interviews were conducted and audio recorded, transcribed, and used to develop a more comprehensive 20-question electronic survey using Qualtrics. A response rate of 46%, or 23 of 50 residents, was attained, including partial responses. Survey respondents consisted of 48% male and 52% female residents, with every postgraduate year level represented. All participants reported having reflected on at least one operative case. The most common frequency of reflection was every day, at 42%. Reflection was most often immediately post-operative, 79%, though this was not routine. When residents did reflect, time was spent most on weaknesses, 48%, and self-improvement, 33%. Primary methods of reflection were categorized as oral, mental, or written, with the most popular being mental at 75%. When stratified by postgraduate year, survey respondents were separated by postgraduate year 1 to 3 for junior residents and PGY 4 to 7 for senior residents. Selecting from a list of reflective goals, a majority of junior residents chose identifying weaknesses, or 67%, as their primary goal, while senior residents focused on self-improvement at 42%. Senior residents included linking experiences as a component of reflection more often than junior residents. Junior residents most commonly selected deliberation at 67%, self-examination at 67%, and goal orientation at 67% as essential components of reflection. Senior residents most commonly selected linking experiences 67% and consistency 67% as essential components of reflection. Junior residents reported no preference of reflection frequency, while a higher proportion of senior residents reported reflecting every day. All junior resident situational reflectors reported priming by unexpected complications, judgment, and OR team performance. Reflection primers were reported less commonly among senior residents, including judgment at 50%, attending feedback at 50%, and unexpected complications, 33%. Senior residents reported higher rates of reflecting intraoperatively than junior resident counterparts. No set time of day for reflection was more common among junior residents. 25% of senior residents reported reflecting during travel time. Primary reflection on weaknesses was twice as common in junior residents compared to senior residents. Similarly, senior residents reported primary reflection on self-improvement and judgment more often than junior residents. Variation and utilization of multiple methods of reflection did not drastically change between junior and senior residents. Mental reflection was the most popular method among junior and senior residents. Only senior residents reported oral reflection as a primary method of reflection. Most common mental reflective activities for all residents were mental rehearsal, reliving the experience, and internal narration. Junior residents reported reading literature as the only form of written reflection, while senior residents' primary activities included note-taking, rereading literature, and rereading patient notes. All senior residents reporting written reflection indicated note-taking activities. The majority of junior residents indicated a seminar on directed reflection would be beneficial to their learning, while no consensus could be determined from senior residents. A clear majority of junior residents indicated implementation of a reflection-based tool set would be beneficial to their education, while equal proportions of senior residents were for and against reflective tool implementation. In conclusion, at baseline, surgical residents reflect independently as part of their surgical training using a combination of mental, written, or oral reflection exercises. A majority of residents primarily reflect mentally. Differences in reflection among junior and senior residents were seen regarding topic, timing, and recall. Further investigation into the value and process of reflection during residency and its impact on advancement and competency is needed. Further, there's awareness that junior residents would be interested and ready to receive such reflection implemented tools and teaching. Thank you for your time and attention during this presentation. I'd be happy to take any questions via email as attached. Thank you.